Good evening, all. Myself, Dr. Kiran Varma, working as head of the emergency medicine, Yashoda Hospitals, Somajiguda. So, I would like to take this as an opportunity to invite you all for the series of webinars connected by Yashoda Group of Hospitals of Emergency Department in association with SEMI and NBI. So, I claim that we means ER physicians are the masters of resuscitation. So, we do wonders for the matter of resuscitation. So, as you all know that we have come up with interesting topic every week. This time also, I make sure that you don't get disappointed with this topic for today. So topic for today is damage control resuscitation, so which is very essential for emergency department, which we need to focus on, which we need to improve, which we need to strengthen upon. So to enlighten about this particular topic, I would like to welcome Dr. Kondle Raghu, who is Senior Emergency Physician, Head of the Department, Yashoda Hospitals, Malakpet. So with this short introduction to the topic and the speaker, now I would like to hand over the forum to our speaker, Dr. Kondle Raghu. Raghu sir, please take over the forum.
Yeah. Good evening, everyone. Thank you, Kiran, for the kind introduction. Yeah, today's topic will be on damage control resuscitation. So we all know trauma is one of the leading cause of death secondary to hemorrhage. It can be of any of the polytrauma. So first, the care starts from the pre-hospital care. So it can be a first aid care or a body care, then the initial pre-hospital care. And then once the pre-hospital care is initiated, then we start from the care en route, that may be the ambulance. Then once the patient received in the ER, then the resuscitation at the trauma center or the trauma bay. Then when the patient is unstable, he may be predicted to the damage control surgery and hemostasis, and then will be subjected to the definitive care. Damage control actually is a Navy term defined as a capacity of a ship to observe the damage and maintain the mission integrity. So this is actually formed by the colleagues of the traumatology. So the adaptation of the term damage control to the field of traumatology can be credited to Schwab and colleagues in 1993. Its dominant principles are more accurately rooted in 1976, addressed by the Lucas and Leatherberg to the American Association for Surgery of Trauma. So coming to the introduction, bleeding is the most common preventable cause of trauma deaths. So it accounts for almost 30 to 40% of deaths. So the early and rapid control of hemorrhage is a mainstay of any trauma management. So coming to the resuscitative principles of trauma. For the 4 settings, we have the pre-hospital care, the emergency department, the OR, and the intensive care unit. As you can see this ladder and the snake, which you can see, the first is the initial field dressing. So initial field dressing, what we do, whatever it is, a simple thing is put a pressure bandage and limb elevation so that there's a bleeding stops. Then whatever it is available, the topical hematostatics can be applied. Then nothing is applied, you can just apply a tourniquet, but see what is the tourniquet time applied and when you are relieving the tourniquet. Then the hemostatic resuscitation. Then once the patient has landed in the ER, the hemostatic resuscitation, then the massive transfusion protocol starts. Then if the patient needs a surgery, he will be subjected to surgery. Then you can use the factor 7A. So damage control resuscitation it starts from the pre-hospital care ER to the OR. So the resuscitation, once he sets into the ER, we have to have a rapid diagnosis. Then the crystalloid should be limited. Then the 1:1:1 transfusion protocol should be subjected, like the PRBC, FFP, and the platelets. Permissive hypotension should be maintained. Rapid anatomical control, that is controlling the source. Then if needed, we have to go for the antifibrinolytics. So coming, this is a coagulation cascade. So we all know about the coagulation cascade. So in the trauma, the extensive pathway comes to play actually. So where when there is a damage to the endothelial tissue secondary to the trauma, tissue factors get activated, then there is a damage which is there. So what is resuscitation induced coagulopathy? So once the patient is subject to the ER, so the patient or the victim, so in the hypotension, there will be a transfusion of fluids or RBC. So patients may be on anticoagulants or any antiplatelet drugs. So he may be having a personal history of alcohol history, then be a genetical issue where the clotting disorders may be there. And when all these are there, the patient may be subjected to hypothermia secondary to the fluid resuscitation, or the patient has been hypothermic secondary to the trauma, and the patient has been subjected to the acidosis secondary to hemorrhage following by shock, patient landing into the acidosis. So in the resuscitation induced coagulopathy, is a consumption of coagulation factor, and there is dilution because of the massive transfusions, so which may be lead to the hypothermia, acidosis, which is compounded by the alcohol and drugs. So that triad of death, which is, we all know that it is the hypothermia, coagulopathy, and acidosis, has to be monitored. So this is what I was talking, the triad of death or the trauma triad of death, the acidosis, coagulopathy, and hypothermia. So whenever there is a hemorrhage, there is a severe blood loss. So what it leads, there will be acidosis. Acidosis, what is, it leads to the decreased myocardial performance, then which leads to the decreased body temperature, which leads to the hypothermia, and this leads to the decreased coagulation, and which leads to, in turn, the blood clotting problem, that is nothing but the coagulopathy, and which in turn leads to the increased lactate in the blood. So this is a vicious cycle which goes on. So what does acidosis do? It is a myocardial depressant where the catecholamines have a stunned response. So the duration of acidosis is related to the, the duration of acidosis and hypotension is related to the abdominal coagulation. So as we all know, when we dump crystalloids, so we all patients leads to the crystalloid-induced acidosis. So there should be a caution when you are giving the crystalloids or the fluids when you are dumping it. So excessive chlorides aggravates again acidosis. So it is treated by improving the tissue oxygen delivery. So the other triad is hypothermia. So we all know of the classification of mild, moderate, and severe. Severe is nothing but less than 28 degrees. Moderate is 28 degrees to 32 degrees, and mild is 32 to 35 degrees. So there is a strong relation between temperature and survival. So the mortality is 100% when the patient lands into the temperature less than 32 degrees. So mild hypothermia, there is a chance of again thrombocytopenia. And when hypothermia is severe, the function of clotting enzymes is reduced. So coagulation test should be performed at 37 degrees and do not adequately reflect in vivo state. So other thing we have to monitor is the hemodilatation. So whenever the trauma victim comes second to the hemorrhage, so we have the intention of dumping the fluids when we don't have a blood products ready, or when the patient is in the peripheral center, when the blood products are not available, when the fibrinolytics are not available, antifibrinolytics. So there's a chance of patient getting adequate or more of the crystalloid initiation. So aggressive fluid resuscitation with crystalloids again leads to a hemodilation. Transfused PRBC are a plasma poor, and factor replacement given late, again it leads to hemodilation. And coagulation is affected when the factors are below 25%. So what is the literature saying again regarding the acute coagulopathy of trauma? As said by K. Brohi or J. Singh, the Journal of Trauma, so 25 to 30% have altered coagulopathy by the time they receive to the ER. and which subjects to 4% mortality higher than the normal thing. And as the time progresses, the mortality rate increases to 8 times once it sets into the 24 hours. And they are already mentioned, also mentioned that as higher transfusion requirements, longer ICU stay and hospital stay, longer the ventilator days, which again leads to the higher incidence of multi-organ failure. So this is how the triad will run from as the time progress. So coming to the pathophysiology. So it is present at the time of injury. So the tissue injury and the hypoperfusion ECTOs. So there is a activation of the protein C thrombomodule complex, so which leads to the hyperfibrinolysis and hypocoagulation. So what does the trauma do? So because of the shock, because of the hemorrhage, the patient lands into shock. This is a tissue injury, the classical ride of your hemodilation, hypothermia, acidemia. So which results, what does it do? It subject for the endogenous response. That is, there is an increased activated protein C, and there is an endothelial glycocalyx disruption is there, and you can see the platelet function exhaustion and fibrinogen depletion. So which again leads to the acute traumatic coagulopathy. That is, there is a autoheparinization, hyperfibrinolysis, reduced clot strength, and reduced thrombin formation. So this is nothing but the hyperfibrinolysis. So hyperfibrinolysis. So once there is a endothelium tissue injury, then there is a tissue platelet activation. Again, the FDPs, the fibrin and the thrombin is getting released. So what is happening in the trauma-induced coagulopathy? So once there is a injury, then there is a pre-hospital resuscitation. So once the acute traumatic coagulopathy, what is happening? There is a hyperfibrinolysis and hypercoagulopathy stage, which leads to the trauma-induced coagulopathy. And in pre-hospital resuscitation. So in hospital resuscitation, we can see the resuscitation-associated coagulopathy. It can be secondary to the crystalloids or it can be written to the blood products. So what is happening here? There is a dilution acidosis, then high acidosis, hypothermia. There is a consumption of all your coagulation factors. So which is leading to the trauma-induced coagulopathy. So coming to the diagnosis part. So diagnosis again, the latest technology of the TEC and ROTEM delta. So there is a when there is a high index of suspicion in a severely bleeding with a hypoperfusion, when the base deficit is more than 6 milliequivalents per liter, when the serum lactate is more than 2 millimoles per liter, or when there is a elevated PT or APTT 1 point time of the more of the normal. So we have the thromboelastogram, the TEG or the ROTEM. ROTEM is nothing but a rotational thromboelastogram. So this is what the normal thromboelastogram. So we have the 5 factors in this. So the first is the R. The R is nothing but your reaction time from the first significant of the clot formation. So we are first seeing only in the coagulation part. So then is the K, that is K is nothing but the achievement of certain clot firmness. So the distance for between RK, so which is we are measuring the angle, that is angle is nothing but the kinetics of the clot development. So from this angle to the medium maximum amplitude, which is a maximum strength of the clot. So then comes the LY30. LY30 is nothing but the percent lies 30 minutes after the maximum amplitude. So we have the coagulation part and the fibrinolysis part. So this is what the TEG or the ROTEM, when you can see this. So the first thing is your normal this thrombin formation. So you can see the other thing. So this is the normal part. And the second thing is we can the spindle shape, so which we can see in the anticoagulants or hemophilia. So this again, it can occur in the factor deficiency, or you can see the RK is prolonged, or the maximum amplitude or the angle is decreased. So this shape you can see when the patient is on platelet blockers. That is nothing when the patient is in thrombocytopenia, thrombocytopathy. So when the R is normal, K is prolonged, and median maximum amplitude is decreased. And this is again the fibrinolysis with the urokinase, streptokinase, or the TPA. So where R is normal, MA is a continuous decrease, LY30, which is more than 7.5%, and LY60 is more than 15%. And this shape you see in the hypercoagulation, where RK is decreased and MA angle is increased. And this shape you see in the DIC stage 1, where there's a hypercoagulable state with secondary fibrinolysis. And this shape you see in the stage 2 hypocoagulable stage. So these are the different types. It can be seen when they are subjected for the TEC. So the thromboelastogram parameters and the incidence. So the R time is the first time to clot formation. So it is 5 to 10 minutes. So if it is more, the treatment option left is FFP. The K time is the time till the fixed strength. It is 0.5 to 3 minutes. The treatment option is FFP and cryoprecipitate. Alpha angle is the speed of fibrin formation. So it is 50 to 75 degrees. The treatment is cryoprecipitate. MA is the maximum vertical amplitude. So it is 50 to 70 mm. So treatment are platelets and LY30, the percentage of amplitude reduction at 30 minutes. So the treatment option is tranexamic acid. So the massive transfusion protocol, when you activate it, you do a rapid TEC. So the ACT, it is more than 110, we give FFP. The angle is less than 60, we go for cryo. If the MA is less than 50, we go for platelets. If the estimated percent lysis is more than 15%, we give aminocapric acid. So reassess rapid TEC in 30 minutes. So why we are talking about the damage control? So whenever there is a trauma settings, so there is hemorrhage and there is loss. So simultaneously the patient are subjected to fluid administration. It can be a boluses or massive fluid. So where they are exported for the operation, and simultaneously there is a loss of tissue perfusion, the loss of clotting factors, there is decreased O2 carrying capacity, and there is intravascular colloids. So again, which leads to the death triad, that is your coagulopathy, hypothermia, and acidosis. So in these critical patients, there is a limited physical reserve, and attempts to provide definitive care lead to a physiological instability. So this is a vicious cycle of your lethal triad of death. So aggressive fluid resuscitation, what is happening again here? So there is increased mortality. So we can see the organs affected because of your aggressive fluid resuscitation. There is a dilution of coagulation factors, the contracting vasoconstriction, increased blood loss because of the decreased oncotic pressure, and the catecholamine's release is decreased here, and vascular resistance to catecholamines increases here, and activation of inflammation, the tumor necrosis factor or interleukin, which is leading to the systemic inflammatory response syndrome, and damage to the endothelial integrity because this is acting, this is to the secondary to the capillary leak. And there is a increased capillary permeability, which is leading to acute lung injury, alveolar lung injury, or the acute respiratory distress syndrome. So the myocyte active potential decreases, so whereby patient landing into the ventricular dysfunction because of the decreased cardio output, and the chances of arrhythmias are more. So there's a intestinal permeability is increased, bacterial translocation is there, patient will subjected to the ileus, and patient will present in the abdominal compartment syndrome, and there is a anatomic dehiscence. So membrane polarization decreases, and there is a disruption of phosphorylation of the cellular edema and apoptosis. Because of the aggressive fluid, there is a hypothermia electrolyte imbalance, so which leads to all these increased mortality, cardiac and pulmonary complications, GI dysfunction, coagulation disturbances and blood loss, altered immunological and inflammatory mediators. So why we are talking about the damage control resuscitation? It was developed to work synergetically with the damage control surgery and prioritize the non-surgical interventions which reduce the mobility and mortality because of your trauma or hemorrhage. So the damage control resuscitation, we need a systemic approach to exsanguinated trauma patients. So why? Because the rest of coagulopathy should be there early. There should be a restoration of physiological stability, so which all leads to the improves outcome. So the damage control resuscitation, it is like in the intensive care unit from the local to the tertiary transfer, from the intervention from the OR to the AR, to the resuscitation B from level 1 to the community, and transport from the air to the ground. So this starts from the scene of injury it can be a urban or rural. So scene of injury from urban or rural to the transport, then resuscitation bay, intervention from leading to the intensive care unit. So the damage control history, so this was initiated by the US Navy. It means nothing but the capacity of the ship to observe the damage and maintain its mission integrity. So the principle of damage control is nothing but decreasing the mortality at the expense of increase in the morbidity. So we have to maintain the permissive hypertension. It's nothing but the act of maintaining a blood pressure lower than the physiological levels in a patient with hemorrhagic blood loss. So the practice is employed in order to maintain an adequate vasoconstriction, to maintain the organ perfusion and prevent an underlying undesired coagulopathy during the initial fluid resuscitation. So the principles is nothing but your balanced resuscitation of 1:1:1, maintaining a permissive hypotension, early hemorrhage control, avoid the hypothermia, minimalizing the crystalloid administration, functional coagulopathy correction, and tranexamic acid if indicated. Yeah. So the indications are, these are the different injury complexes. It can be from the multi-regional exsanguination with the visceral injuries, multi-regional injuries with competing priorities. So major abdominal vascular injuries with the visceral injuries, and multiple penetrating or high energy blunt trauma or the torso trauma, and difficult to access the major venous injuries. So the damage control indications, the physiological, the lab parameters, patient in grade 3 to grade 4 hemorrhagic shock or extremis, response to fluid therapy, which can be a transport or non-responders we take. When the pH is less than 7.2 or the base deficit, it is more than 6 milliequivalents per liter, and the lactate is more than 2 mm per liter. The PT, APTT, it is 1.5 times more than the normal, and hypothermia when the temperature is less than 35 degrees centigrade. So damage control trauma, the resuscitation is again balanced resuscitation, hemostatic resuscitation, following the massive transfusion protocol, correcting the acidosis timely, and maintaining a temperature protocol control. So we all, when the patient doing a damage control, so most of the time, because we in the endemic country, being an endemic country, the hypothermia chances are less, but we should not forget, because we working in the ER, in these climates, when the ACs are running, the temperature has to be monitored and has to be maintained. So the damage control surgery is nothing but surgical control of hemorrhage. Simultaneously, there should be a contamination control. Again, a good intensive care and return to the definitive surgery. So surgery control of the hemorrhage, contamination control, intensive care, then return to the definitive surgery. So what is balanced resuscitation? So hypotensive resuscitation or controlled resuscitation, or the permissive hypotension, targeting a blood pressure of 90, not targeting more than 100. So the balance risk of decreased tissue perfusion with benefits of prevention of your coagulopathy. So initiation of 1 liter of crystalloids initially, and maintaining a target of systolic blood pressure 80 to 90, except in head injury. Keep the vein open or radial artery just palpable before the surgical control of hemorrhage, as said by the Japanese in the Journal of Intensive Care in 2017. So what are the evolving strategies of fluid resuscitation? Two strategies. One is the aggressive fluid resuscitation. One is the delayed resuscitation of the bleeding control. So the ideal resuscitation fluid, still it is a debated topic, which fluids to be given. So the fluid of choice, again, it will be a crystalloids. It are easily available, inexpensive, preferred fluids in resuscitation of trauma victims. And colloids, expensive, availability is a concern, so which doesn't come into the priority of resuscitation. Next, other things, the protein colloids, your albumin, gelatin solutions, non-protein colloid starches, and dextrans. So these are different articles taken into the resuscitation of fluids. The first one is the NEGM. So this is a safe study. So in this, the inpatient in the ICU, the use of the either 4% albumin or the normal saline for the fluid citations results in similar outcomes at the 28 days. So this was a comparison of albumin and saline for fluid resuscitation in the ICU. So next is the hydroxyethyl starch or saline for the fluid resuscitation in ICU. Again, this was published in the NEGM. So the conclusion says, in patients with ICU, there is no significant difference in the 90-day mortality between patients resuscitated with 6% HES or saline. However, more patients who received resuscitation with HES were treated with renal replacement therapy. So the colloids have damaged the renal function. So the next study, which was published in the JAMA, so effects of fluid resuscitation with colloids versus crystalloids. So the conclusion reveals is, among ICU patients with hypovolemia, the use of colloids versus the crystalloids did not result in a significant difference in a 28-day mortality, although the 90-day mortality was lower among patients receiving the colloids. So this finding should be considered the explorative and requires a further study before reaching the conclusion without the efficacy. So we all know the ROSE concept, so which was adopted by Malvern. So this was taken into the World Journal of Surgery. So the ROSE concept is nothing but R stands for the resuscitation, O stands for the optimization phase, the S for the stabilization phase, and the E for the evacuation phase. In the resuscitation phase, salvage or rescue treatment with the fluids administered quickly as a bolus of 4 ml per kg over 10 to 15 minutes. So the goal is early, adequate, lower, the goal directed fluid management. So must be positive, and suggested resuscitating targets are MAP of more than 65, the cardiac index more than 2.5 liters per minute square, and the positive pressure ventilation less than 12%, and the left ventricular end diastolic, that is more than 8 centimeters per meter square. So the optimism phase where it occurs within hours. So ischemia and reperfusion and degree of positive fluid balance may be a marker of your severity in this phase. So the risk of polycompartment syndrome is more here. So unstable compensated shock or requiring a titration of fluids to the cardiac output. So the targets again are MAP of more than 65, cardiac index more than 2.5, PPV less than 14%, LVD of more than 8 to 12% square, and then intra-abdominal pressure should be less than 115 are monitored here, and the APP more than 55 is calculated. So the preload optimized with a GD of 640 to 800 ml per meter square. So next is the stabilization phase. It evolves over the days. So the fluid therapy only for the normal maintenance and replacement only here. And the absence of shock or threat of shock. So monitor daily body weight, fluid balance, and what is the organ function. And you should target the neutral or negative fluid balance where the EVL WI is less than 10 to 12 ml per kg, where the PBV PBVI is less than 2.5, and the IAP is less than 15 mm Hg, and the ABP is more than the 55 mm Hg. And the last is your evacuation phase. Patients who do not transition from the EBB phase of shock to the flow phase after the second hit, they develop a global increased permeability syndrome. So where you can see the patients in the fluid overloaders causing a end organ dysfunction. So when you resuscitate more with the aggressive with the fluids, like initially we have seen like a 4 ml per kg or giving more fluids. So this can be, you see the late goal directed fluid removal or the de-resuscitation to achieve the negative balance. So need to avoid over enthusiastic fluid removal resulting again in a hypovolemia. So what are the resuscitation in special groups? So this was again taken from the Ramesh et al., the International Journal of Emergency Medicine. So the pediatrics, it is limited to 20 ml per kg body weight only. Geriatrics again 20 ml per kg, targeting a HP 9 ml per kg and the MAP of 70 ml per kg. And burns, we have to follow the Parkland's formula. Pregnancy signs seen after loss of 1.5 to 2 liters of blood loss. CKD, balanced electrolytes are preferred here. Whenever there is a LV failure patients with a trauma, crystalloids, vasopressors simultaneously to be initiated. And alcoholic liver disease limit to 10 to 20 ml per kg. And when there is a massive blood loss, permissive hypotension strategy to be maintained. So this is again the flow diagram of the initial fluid resuscitation of the trauma. This was taken from the World Journal of Surgery. So the initiation of the first 1 to 2 liters of clear fluid resusc. If there is a non-responder, no source control, pH less than 7.3 and temperature less than 35, base deficit more than 5, we initiate the MBT. Then patient can be subjected to the theater, surgical source control, HBOC or cell saver. So after the fluid, the patient is non-responder, no source control. The pH is less than again 7.3, temperature more than 35, base deficit less than 5, and there's a comments of your PRBCs plus or minus the CT. Sorry. And again, we see the same thing. Again, we have to initiate the MBT protocol. So if we see again the responder, where we have a source control here, pH 7.3 less than, and temperature less than 35, base depth more than 5. So these are again commencing for your PRBC, and this can be, if there's a good response, then we need investigate as necessary, theater or conservative management as indicated, and then followed by a judicial clear fluid use. And the last one is a good response source control, pH more than 7.3, temperature more than 35, base depth less than 5. So this has to be followed. So the systolic pressure goals during resuscitation. So the penetrating BP 50 to 70, blunt trauma 80 to 90, TBI 100 to 110, maintaining the MAP of more than 70, clearance of lactate the target of less than 2, base depth is less than 5, improving pH to more than 7.3, normothermia or at least maintaining a temperature of 35 degrees. So the responders achieved set target goals, non-responders fails to reach set target goals, and transient response temporarily reach set targets but then decompensate later. So the hemostatic resuscitation. So massive blood transfusion, loss of more than 1 blood volume, that is more than 10 units of PRBs within 24 hours. So the hemostatic resuscitation, what we follow, that the FFP platelets and the PRBC of your 1:1:1, and higher plasma and platelet ratio early in the resuscitation phase were associated with the decreased mortality in patients, as was published in the PROMIT study. So the blood targets, no statistically significant difference in mortality at 24 or hours or at the 30 days. So exsanguination in the first 24 hours significantly decreased in the 1:1 in the Sonic group versus the 1:1:1 group, which is from 9.2% versus the 14.6%. So more patients achieved hemostasis in the 1:1:1 group compared to the 1:1:2 group, which you can see 86%, which the other group is only 78%. There is no difference in the complications between the two strategies, between the 1:1:1 or the 1:1:2. So early use of blood products. So blood and the other infusion fluids can be heated from 5 degrees to 37 degrees at the flow rates when you adopt this M warmer system, and the flow rates can be 150 ml per minute. So one charged battery can heat up to 2 liters of cold fluids at 5 degrees or 4 liters of fluids at room temperature, that is 21 degrees to your body temperature. So when you're following this massive transfusion protocol, always it's better to use the M warmer system. So the prediction of the massive transfusion. So what is a trauma-associated severe injury? So it has the variables of systolic blood pressure less than 100, heart rate more than 120, HB less than 7 grams, positive fast with a hemodynamic instability, pelvis and the long bone fractures, base excess more than 10, and INR more than 1.5 of the normal. The assessment of the blood consumption, and these the components are the systolic BP less than 90, heart rate more than 120, penetrating mechanism, and the positive fast. So the traumatic bleeding severity score we'll see in the next slide. So each thing is the factors we have taken is here the age, systolic blood pressure, the fast and the pelvic fracture, and placement of the arterial lactate concentration at the time of admission. So simultaneously they are given points for each of these scores. So we have this traumatic bleeding severity score where you have the systolic BP, fast, the pelvic fracture, and the lactate concentration. So basing on this, we can predict the mortality of low risk, moderate risk, or the higher risk. If the TBS is more than 17, there is a high risk. If the TBSS is 11 to 16, it is the moderate risk. If it is less than 10, the risk is low. So the TBSS protocol for activation of massive transfusion is in this diagram. So caution should be noted when you are going for the pharmacological thromboprophylaxis, because it is recommended within 24 hours after the bleeding has been controlled. Again, it comes from grade 1B only. Early mechanical thromboprophylaxis with intermittent pneumatic compression, it is grade 1C. Early mechanical thromboprophylaxis with anti-embolic stockings, it is grade 2C. So these guidelines were taken from the European guidelines. So we all know the hemorrhage control in the need. So one on the floor and the four more. So these are the four major organs which involve. So you can see a massive blood loss. It can be a chest trauma, abdominal or a retroperitoneal trauma, pelvis or the long bones. So the thing is, it can be control or direct external compression using your tourniquets, splintings of the fractures, chest tube insertion, pelvic binder application, doing a emergency department thoracotomy, and the new entity of your resuscitative endovascular balloon occlusion of your aorta. So doing emergency department thoracotomy, a trained surgeon in the ED, if he's available, or if he's available in the hospital. So patients in the extremis and suspected torso trauma, so go for the direct hemorrhage control, cross-clamping of the aorta or open cardiac surgery. So these are the things you can do in the emergency department thoracotomy. So the next thing is the new one is your Ribova. So the indications are traumatic cardiac arrest, abdominal or pelvic trauma. So the contraindications we see here, whenever there is a thoracic hemorrhage, it is contraindicated. So it has 3 zones. Zone 1 is the catheter from the left subclavian to the iliac, and zone 2 is from the celiac to the renal, and the zone 3 is the distal to the renal. Okay. So the next slide, I will play the diagram, the video. So here, Ribova has taken the FDA clearance. So this is how the catheter is there. So it is a 7 French compatible catheter. So you have atraumatic P-tip as we have on the central lines for the safe insertion. So it has the integrated arterial line for the pressure monitoring. And it has a compliant occlusion balloon, so which can be occluded at the different levels from this subclavian celiac, the renal, and the distal renal. So the guide wire is free, kink resistant, and ethanol shaft. We have the marks there. So this is the arterial monitor way we do. This is how it is introduced. Once you introduce the catheter, you remove the Then there is a balloon flush for inflating the balloon there. So this is below the renal. So this is at the celiac and renal, and this is at the so this is how the blood pressure is monitoring and your balloon is included the deflate the balloon. So this is the recent trial, the UK Ribova trial, which was published just last month. So what they did is, so it was a multicentral open label trial. So it was conducted in 16 major trauma centers in the UK. The funding was the National Institute of Health Research, and the registration was done. And the inclusion criteria was trauma patients aged 16 years or older with confirmed or suspected life-threatening toss or hemorrhage. Exclusion criteria: patients known or thought to be pregnant with injuries clearly not survivable. So the intervention was placement of Ribova for resuscitation in zone 1, that is the descending aorta, or zone 2 above the aortic bifurcation based on the clinical judgment. So the intervention, the placement of Ribova for resuscitation in zone 1 or zone 2 based on the clinical. So the comparator, the control group received a standard care provided at a major trauma center, including the intubation, blood product transfusion, interventions like the tornitic application, and early operative or endovascular hemorrhage control. So the primary outcome was at 90 days, and the secondary outcome were taken as mortality at 6 months, the need for definitive hemorrhage control procedures, time to commencement of definitive hemorrhage control procedures, and the complications were seen in the secondary outcomes, length of the hospital stay, blood product use, and cause of death. So these are the results: 120 patient recruitment, 120 planned, and 90 are randomized, 46 randomized to Ribova plus in the subjective group, and 44 for the SA group. So one patient declined the participation of the environment. So the pathways, so this was a conclusion. The UK Ribova is a significant step in our ongoing pursuit to enhance the trauma care. It serves as a reminder of the importance of rigorously testing medical interventions in varied settings and populations. So this study underscores the need of more extensive research in diverse clinical settings to fully understand the role of Ribova in trauma care. So we all know the pelvic fracture classification, the tiles A, the ABC, the A, B1, B2, B3, and the type C, and the Young and the Burgess classification. So the source of bleeding in the pelvic fracture, 40% associated with intra-abdominal injury. In this, 80 to 90% are venous, 10 to 15% are arterial, and fractured end of pelvic bones. So there was a study which was published like external fixation versus the temporary fixation. In this, 186 patients were enrolled. In this, 93 were external fixation and 93 were temporary. So 24 hours blood transfusion requirement was more in temporary fixation. Hospital stay was more in temporary fixation. Mortality, as you see, more in temporary fixation. So external fixation is easy and rapidly application in ER. So the other entity we all know when we have a pelvic trauma is pelvic bender, which is non-invasive, easy to apply, inexpensive, and access to the abdomen. So this is the algorithm. So unstable pelvis, put a temporary pelvic bender. If it's stabilization no, then fast DPL. If it is negative, go for angioembolization. If the fast DPL is positive, laparotomy or pelvic packing. Then ICU, definitive imaging and definitive fixation. So the pharmacological agents, we have the tranexamic acid. We have many crash trials which were published. Activated factor 7, prothrombin complex concentrate, fibrinogen concentrate, and the calcium. So the antifibrinolytics inhibits the plasminogen activation and plasmin activator by preventing the fibrin clot lysis. So tranexamic acid significantly reduces the mortality in bleeding trauma victims as it was published in the CRASH 2 trial. So the loading dose is 1 gram infused over 10 minutes followed by an infusion of 1 gram over 8th hourly. This is a grade 1A indication. To be administered to the bleeding victim within 3 hours after the injury. This is grade 1 2B. So there was study published which was given within 3 hours and later on 3 hours. So there was a good survival of patients which will given within 3 hours. The other pharmacological is the prothrombin complex concentrate, initially used to immediate reversal of the warfarin. So PCC contains vitamin K dependent factor 2, 7, 9 and 10. Advantages: no need of ABO typing, no need of plasma thawing, avoids fluid overload, faster normalization of coagulation factors, and decrease transfusion related complications. So the dose is 25 to 50 international units per kg, total dose of 3,500 units. Next thing is your fibrinogen. Rotam guided fibrinogen administration reduces the transmission rates and post-operative blood loss. Fibrinogen and PCC avoided PRBC transfusion in 29% versus the FFP 3%. So maintaining fibrinogen levels more than 100 mmg per deciliter. So next is your cryo, alternative to fibrinogen concentrate. Disadvantages: availability, allogenicity, need for blood typing, and time consuming thawing. So the next pharmacological is activated factor 7, used for hemophilia. No difference in mortality when compared with the placebo. Available for off-label use only at last resort of your controlled bleeding. So as we all know, the lower levels of calcium are increased, associated with increased mortality. So because the citrates chelates the calcium here, calcium should be monitored periodically, because after every 10 units, there's a chelation in calcium has to be administered. It should be maintained at least 0.9 millimoles per liter. So rewarming has to be followed, should not be forgotten. It can be with blankets, warm fluids of 40 to 42 degrees, removal of the wet clothes once released in the ER, increased ambient temperature 28 to 29 degrees, external body warmers, body cavity lavage with warm fluids, or early exposure of open body cavities. So then next topic is the remote DR. So it can be there in anywhere in the pre-hospital setting or ambulance or airfield. So it has a stepwise approach to hemostasis, stop hyperfibrinolysis with tranexamic acid, support clot formation with fibrinogen concentrate, increase the thrombin generation with the PCC. So fixed ratio of blood transfusion and factor concentrates has to be used in the remote DCR. So as we are coming to the conclusion, definitive hemostasis is the first requirement and it's prioritized in the concept of DCR. Principle of permissive hypotension is utilized until hemostasis is achieved. Then normalization of perfusion will become the new goal. Assessing the adequate resuscitation will require continuous vital signs and unit output monitoring, as well as reassessment of rebleeding, hypoxia, anemia, coagulopathy, and electrolyte derangements and blood gas abnormalities. So the windows of circulation has to be monitored. Normalization of lactate and base excess is correlated with resolution of shock state and improving of the mortality. So when ACS has published suggested VCT thresholds for goal-directed therapy on specific instrument, endpoint resuscitation in traumatic hemorrhagic shock typically occurs outside the ED, as these patients often require treatment in the operating suite only. Stage complete operations may not occur until the patient's hypothermia, acidosis, and coagulopathy are corrected in the ICU setting. That is nothing but your trauma triad or your death triad. So the goals should be rapid transport and balanced resuscitation, tranexamic acid within 3 hours, massive transfusion protocols to be established, early use of blood products in a predefined ratio as 1:1:1. Tech can guide your further transfusion, correct acidosis, prevent hypothermia. Early surgical control of hemorrhage has to be done. So this is your ER algorithm. So because it's all but day time consuming, I will not go into it. So damage control for he who fights and runs away may live to fight another day, but he who is in the battle's lane can never rise and fight again, as said by the Oliver Goldsmith. So this is my ED at Narayana Medical College. So damage control, resuscitation. Thank you.
So that was a wonderful talk given by Dr. Raghu sir. So he touched almost all the entities of damage control resuscitation, including components of DR, lethal triad, and TAG, ROTEM, fluid resuscitation strategies, then close concept, then finally RIBOVAR, which is evolving concept and all. So thank you, Dr. Raghu sir, for enlightening on a particular topic. Thank you so much. Undoubtedly, this is an elaborate and extensive talk. So I think it would be useful for our ER residents and our ER fraternity as well. So if you have any questions, we can take up, sir. So far, no questions. So I would like to add one thing, sir, if you permit me, Raghu sir.
Yeah, you can go ahead.
So regarding registration, there is a new trend which is going to come up. Already it is under evaluation and many research are going on it and many trials are going on. Like STO2. One thing is like STO2 instead of SPO2, what we see regularly. So they are working on STO2.
Okay.
It's like a micro saturation in the microvascular level.
Yeah.
Microvascular saturation, STO2. So microvascular in the sense like where arterioles and venules forms a microvasculature, it reflects balance between oxygen delivery and oxygen consumption. So there is like SPO2 kind of machine, infrared machines, which measures STO2 levels. So that is one of the recent trends which is happening in registration, study circles and all. So if we have in the near future, it would be helpful for us. So like a TEG and ROTEM, where we use, specific components of blood. It's like cryosun, cryoprecipitates, FFP, and Trenexa like that. So if it comes in the near future, so STO2 would be one more advantage, and it would help us a lot. So that I wish it would come soon to our thing. Then one more thing like a DO2, oxygen delivered to the tissues, DO2. So as it depends on cardiac output and CaO2, CO2 means arterial oxygen saturation. So that is our main concept of DSER is to minimize the fluid restriction and to give the blood products, because we need to reduce the tissue hypoxia. So how to reduce tissue hypoxia is only by giving the blood products, because hemoglobin carries the oxygen. So they are working on these two things in the recent trends, which are coming, which are like recent trends, evolving trends in the resuscitation. Then, as you said, after registration, we need to think about endpoints of registration as well. So that is very, very important in terms of there are many ways to look for endpoints of registration, like cardiac output, then many other things which we need to look upon after registration as well. Then, as you said, one thing you touched upon, so like aggressive versus limited fluid registration. Yes, still it is controversial, as said by many people, but still many people are thinking that limited fluid restriction is useful in some other ways, like already there is a consumptive coagulopathy. So on top of that, if you give more fluids, it causes dilutional coagulopathy. So it worsens the coagulopathy. So as I said, limited and restricted fluid registration would be helpful in such cases. So these are the things which I would like to add upon. Already you discussed about Riboa. So I think you have touched many aspects of DCR. So thank you so much, sir. So any questions so far? There is a questions from Dr. Saurabh. Sir, can you comment on Ribo versus resuscitative thoracostomy at your center? Your experience with these two procedures?
Because of late, Riboa, there is much use in India only actually. And open thoracotomy is not experienced much, because by the time these patients are getting diagnosed, or think most of the times we are losing it, and we need a skilled surgeon who can handle like the open cardiac massage, or who can do anything only in the ER. So that is still maybe a time-taking aspect of resuscitation in the ED yet to come. So we are more with the asphyxiation. So we used to do the asphyx in the ER itself only. So where it has shown a good results actually. But
Yes.
of late of this Ribo versus thoracotomy in ER, not much centers are doing it, because leave about open thoracotomy, no one is going for the Ribo itself.
Yeah, true, sir. Even we never experienced of using of Ribo and open thoracotomy so far. So good. So yeah, so far no questions. Okay. Since we have no questions, we are about to conclude our sessions. So before that, I would like to thank Dr. Srinath sir for creating such a wonderful platform to impart our clinical knowledge and share our knowledge with our medical and emergency fraternity. Then at the same time, I would like to thank our Yashoda Hospital management for supporting in each and every aspect to conduct this webinar. Then I also thank SEMI and Anbai board for supporting in every aspect of our journey. Then last but not the least, our viewers. So because of our viewers only, our program is getting good viewership, and we are getting they are giving energy to continue our programs as well. So I once again thank all the viewers of our webinar. So with this, we are going to signing off for this week. So we are going to catch up in the next webinar. Thank you all.
Thank you.